As for the MIMIC project, which is the ICU database, the hope is to scale that up to become a global ICU database that will be open to investigators from around the world. We want to involve more people. We want to involve more clinicians in this process of knowledge discovery. We want to open the floodgates of research and keep it from being exclusive to a small cadre of methodologies. There's obviously some challenge to that. We have to make sure that we won't be contributing to more irreproducible research, and the way we are addressing that concern is by making the database public and also making the methodologies as transparent as possible, convincing people to cross-check each other's approaches in their research, do a lot of error checking, validate each other's models, and do that all in the open so that there is more accountability to the robustness of the research that they are presenting. We are extending that outside the intensive care unit. We are working with the emergency department, for example, so that what we are trying to do is to provide a more holistic data source for this research. What we're really trying to achieve is changing the culture in the way we innovate, in the way we discover knowledge, and allowing people to contribute to this knowledge discovery and innovation. Being able to leverage each other's expertise, providing that opportunity to everyone to participate in these events. That is exactly what the datathons and the hackathons are designed for. MIMIC would not have been possible without the help from Philips. Beth Israel Deaconess had a Philips for its information system, and we needed to work with them to be able to archive all the data coming from their systems and provide that data for research purposes. A lot of the data that is being generated now are through different information vendors, and we need to bring the industry partners together so that we have a better design of these databases. There's a strong interest too in what the data could offer. We know that by interrogating the database, we're able to learn more about what products, what devices, what medications would work well with particular subsets of patients or for very specific clinical contexts. This is the idea behind precision medicine, moving away from depending on population studies for practice guidelines and honing in on individual characteristics in terms of individualizing the recommendations for treatments and tests. We take this for granted, but this collaborative approach to problem solving is something that is already there at MIT. This is exactly the environment that we're trying to recreate in our partner universities. Removing the silos that separate the different departments, we think is bringing us a step closer to being able to solve the big problems of our generation. Having different perspectives to the same problem, bringing together different expertise, we think would be a much better approach compared to the previous centuries. And we are fortunate that this is something that is easy to achieve at a university such as MIT. We are interested in data outside the intensive care unit. We would like to interface this with non-clinical data. We would like to interface this with data being collected in the clinics, because all this data would give you a better picture of the totality of the patient. Typically, what happens in the hospital, what happens in the intensive care, are affected by what happened before they came to the hospital. And for now, we don't have access to those type of data. And this is where industry could come in. We really need to be able to come up with more holistic databases so that we are better equipped to be able to answer the questions that we have in terms of improving the care that we're providing to patients.